Good evening, everyone. I just waiting 1 minute for Mr. Hashim to join us.
السلام عليكم يا فندم.
عليكم السلام. Good evening, Mr. Ashab.
ازي حضرتك يا فندم؟
الحمد لله.
سعداء بوجودنا مع حضراتكم والله.
يا فندم احنا الاسعد والشرف لينا. الشرف لينا يا فندم.
عاملين ايه في انجلترا في الجو دلوقتي يا فندم؟
الحمد لله يا فندم، الحمد لله بخير والله.
انا في اسوان الجو بصراحه رائع.
دايما
ربنا يكرمكم يا رب ويبارك فيكم جميعا.
Mr. Ashab will start the webinar today.
Yes, sir. Mr. Hashim is with us or is not joining yet?
Unfortunately, he didn't join yet. Hopefully, he will join. I messaged him, just waiting to join us.
He was just speaking to me on the WhatsApp. I think he's ready to join.
Okay, waiting for him.
Hossam is with us.
Our papers today will be presented by me and our colleague Rami.
Yeah, nice to meet you, sir.
Nice to meet you, Mr. Ashab.
You're from Flemley Park or from where?
Me, I'm working at Worcester Royal Hospitals.
Yeah.
And Rami also, we are working together in the same trust.
Yeah, the most active trust.
It's located in the middle of UK or north or south?
Yes, Midlands.
Midlands, yeah.
I think Mr. Hashim joined us already now.
استاذنا السلام عليكم.
عليكم السلام ورحمه الله وبركاته. دكتور محمد
زي ما عليك.
الحمد لله. انا لسه مخلص السبيشاليتي داي بتاع السباين.
ايه الاخبار؟ تمام.
لوج اوف اند لوج ان.
ما شاء الله.
اسوان بتسلم عليك يا دكتور محمد.
ماشي، ربنا يمنور بيتك في الصور ان شاء الله.
انا في المانيا ان شاء الله يوم الاثنين باذن الله، فهنشوف الجو بقى الجميل اللي عندكم.
برد شويه اليومين دول.
لا برد كتير.
Good. Let's start. اتفضل دكتور محمد حضرتك يعني.
اتفضل يا فندم، اتفضل يا فندم.
انا introduce ده باش اتفضل.
بسم الله الرحمن الرحيم. It's a great chance for me and a great honor to announce for I think the fourth specialty day, Dr. Hashim. Yes, representing the cooperation between the Egyptian Orthopedic Association and the Orthopema, and it's of my fortunate and my big chance to meet my dear colleagues and my dear friends from UK tonight in representing the Orthopema and presenting two papers in the upper limb. Professor Hashim, thank you so much, Dr. Hashim, for your great effort in preparing such an very, very fruitful and very eminent scientific presentation regarding the specialty days. Thank you so much, Mr. Hashim, for this journal club. Please, sir.
Yeah, pleasure, Professor Ashab, and good evening, everyone. So welcome to our monthly journal club between EUA and Orthobema. And today, Rami and Mo will be taking us through two eminent papers in the upper limb. So we'll start firstly with, by Mo, yeah?
Yeah.
Good, okay. So can you share your screen and start the presentation, please?
Can you see my screen now, Mr. Hashim?
Yeah, it's on, yeah.
Good evening, everyone. My name is Mohammed Ragab Shalan, specialist doctor at Worcester Royal Hospital. It's my pleasure today to present our first paper, upper limb. It's about effectiveness of open versus arthroscopic rotator cuff repair. It is randomized controlled trial. Rotator cuff tears are a very common source of shoulder pain and decreased motion. In United States, more than 300,000 rotator cuff repairs are performed annually at a cost of about $3 billion, representing 2.4% of all GP consultations made per year at UK. 28% of population have a full thickness tear at age over than 60, while 65% of patients above 70 have full thickness tear. A six-fold increase in arthroscopic repairs compared with 34% increase in open repairs. There is no consensus on the best method of treatment versus operative versus non-operative.
Mohammed, the slide's not moving.
Not moving?
Share the whole screen.
Yeah. You can see my screen now? You can see my screen, Mr. Hashim?
No.
Yeah.
Yes.
Our paper today about the effectiveness of open versus arthroscopic rotator cuff repair. It is pragmatic, multi-center, parallel group, comparative randomized controlled trial. Involved 19 centers in the UK between November 2007 and December 2012. Published in the Bone and Joint Journal in 2017. The study involved 273 patients were randomly allocated to either arthroscopic repair versus open repair. Surgeon had to perform a minimum of 5 rotator cuff repairs every year to be eligible to take part in the trial. The study started with 3 limbs, non-operative versus open versus arthroscopic repair, but changed in 2009 to two limbs only, open versus arthroscopic, due to high crossover to operative management. Small changes have been made to the protocol over time to reflect changes in the points of outcome data collection and recruitment procedures. Randomization. The study was triple-blinded, patient allocation, assessor, and analyst. The patients were randomly allocated to the group using computer software. The surgeon allocation didn't clearly state how and when the surgeon would know the planned surgery. The assessor, independent consultant radiologist, blind to the type of the surgery performed, and MRI versus ultrasound will be done at 2 years follow-up. The analyst will be blinded to the results. Regarding the PICO of the study, the population are the patient above 50-year-old with degenerative rotator cuff tear. Intervention is the operative management, and we compare between open versus arthroscopic repair. The primary outcomes were the Oxford shoulder score at 2 years, and secondary outcome measures included assessment of function and health-related quality of life using shoulder pain and disability index and the mental health inventory. The outcome assessed was pain and loss of function. Inclusion criteria include age above 50-year-old, degenerative rotator cuff tear, full thickness tear, MRI or ultrasound scan diagnosed, and the patient must be able to consent for the surgery. Exclusion criteria include previous shoulder surgery, dual shoulder pathology, traumatic tear, significant problem in the other shoulder, rheumatoid arthritis or systemic disease, significant osteoarthritic problems, significant neck problems, cognitive impairment or language issue, patient unable to get an MRI scan for any reasons. The result of the study are the primary outcome. There is no significant statistical difference between the arthroscopic and open repair. And regarding the re-tears rate, there is no significant difference also between the two groups, but healed repairs yielded better shoulder score outcomes. Regarding the surgical and the post-operative complication, also there is no significant difference. And both groups showed significant improvement in the function and the quality of life outcomes. Both arthroscopic and open techniques offer comparable outcomes in terms of function, pain relief, and quality of life. No clear superiority of one technique over the other. The rate of the re-tear is high in both groups for all tear sizes. Surgeons can select the technique based on experience and the patient-specific factors. Focus should be on optimizing patient selection and rehabilitation. The study highlighted the need for improvement and enhancing the tendon repair techniques. The strengths of the study include it was large sample multi-center randomized control trial. Randomized control trial study design is the gold standard for evaluating surgical effectiveness. Outcomes were clearly specified with primary and secondary outcomes and how to measure both of them at each time interval. Results were expressed with mean scores, standard deviation, and confidence intervals. Results were reported for each outcome at multiple time points at 8 months and 12 months and 24 months post-operative. The intention to treat analysis was used to reduce the bias. The weakness and the bias of the study include there is no consensus on the superiority of operative versus non-operative treatment, and further randomized control trials needed for this. High crossover rates limit the clarity of the conclusion. As we mentioned before, after 2 years of the study changed from 3-limb study to 2-limb study, and the non-operative treatment group was excluded from the study. There is no clear justification for the starting age, which mentioned in the inclusion criteria, why we started from the age 50-year-old and why we excluded the patient below this age. There is no clear definition of how long to decide if the patient has failed conservative management. Also, the choice of surgical technique and the change to open repair during the operation is left to the surgeon preference, possibly which might result in variable outcomes. Allocation didn't clearly state how and when the surgeon would know the planned surgery, so we don't know the surgeon will know he will go for operative, for arthroscopic or open repair, and when will know this. There is about 27 patients were recruited but not continue with the study, but there is no any information about why this patient were excluded from the study. There is small changes have been made to the protocol over time, so the protocol which started with the study has been changed after 2 years to reflect changes in the points of the outcome, which make a bias of the protocol. There is no clear justification about how many steroids injection the patient can take before we can decide the conservative management has failed, and there is no any outcome measures comparing about the re-rupture or the failure of management of repair after the steroid injection. What criteria to change the arthroscopic to open repair? The protocol didn't mention how will we mask the shoulder during ultrasound. As we mentioned before, all the patient will get ultrasound or MRI assessment after 2 years, but they didn't mention how the ultrasound consultant can be masked from, because actually if he going to do ultrasound assessment, he can know from the surgical scar the patient get open repair or arthroscopic repair. But the study didn't mention how they can mask the surgical scar, for example. The follow-up with MRI or ultrasound might result in bias because actually the ultrasound is operator dependent. There is nothing mentioned in the study which patient will go for ultrasound and which patient will go for MRI scan. Further studies explore the patient reported outcome after 2 years. Thank you.
Thanks, Mo, for the nice presentation. This is a problem of all pragmatic non-inferior trials. So it's very short follow-up, is very small sample, and it gives you a broad line result. You can use it as a guide, but you cannot depend completely on all the pragmatic non-inferiority. So for the superiority trials, you need a huge sample. So you can, and a very good masking and randomization. So you can come with a very consistent answer. But for the pragmatic non-inferiority, it's almost small sample and it's almost short time follow-up, but it definitely has a role. And from the practice, we know that the open is nearly comparable to the arthroscopic. It depends on the surgeon preference and the surgeon experience, but the results are almost comparable. For any question, please, guys, keep it in the chat, and we'll be answering all of them. UKF trial is a very common one, and it's very common one implemented in the practice, in the upper limb practice in UK, and a lot of shoulder surgeons use it as a guide for the decision making between conservative open and arthroscopic. So if you have any questions, any comments on the presentation, please keep it in the chat, and we'll be answering it on time. Rami, just get ready until we see if there's any question coming.
Mr. Hashim, I think my main question is that when we are changing the protocol in the middle of the study, which make a big bias, for example, the study started as 3 limbs and including the non-operative management, and then change it to just only open versus arthroscopic.
Yeah, so for the non-inferiority, it doesn't change the finding of the study. Yeah, there is one limb missed, and this is the change of the protocol makes the study a bit weaker. But as a non-inferiority, it doesn't affect the results. It's still the arthroscopic compared to the open have a comparable function and outcome and results. But the problem is with such a trial, because you're definitely doing a small size, you're doing a very pragmatic one. So you couldn't keep every patient to intended to treat. So with intended to treat, when you put certain patients to a group, you have this group continue to the end of the study, but you end by because it's pragmatic, you cannot change. It's multicentric. You cannot make a full control on the trial. Sometimes one of the limits of the trial goes away. And then because number of follow-up patients are less than you can put as a sample size according to power analysis, then sometimes you miss limb of the study. But the other limbs which continue as intended to treat till the end, they give you a comparable results. So this is the problem with the pragmatic trials. So with the major trials, when you do a superiority trial and it's not pragmatic, it's not based mainly on randomization, you have all the patient going according to intended to treat with a huge sample, even with some lost patient in follow-up, you don't miss a limb of the trial. But because it's a pragmatic small sample, non-inferiority, always with some patient losing follow-up, you start getting one of the limb of the trials away. So, and unfortunately, most of the UK trials are of the same way, it's pragmatic non-inferiority with a small sample size. It's easy to evidence the non-inferiority than to evidence the superiority. You can say this is not inferior to this, but it's so difficult to say this way of treatment is superior to this. With non-inferiority, small sample size, short limbs, and in case you miss some patient for follow-up, or some patient change their mind, or some patient change from a group to a group, so your intent to treat has been disturbed, you easily miss a limb. But this doesn't affect the main protocol. It's a weak point for the study, but doesn't affect the main protocol. Because for your UKV trial, they mainly comparing the open versus arthroscopic. I believe the non-operative limb was an added limb. And because it's nowadays is a very, very common practice, especially above 65. So that's why they keep it as a limb. But with a small sample size, it's very easy to miss one of the limbs. So Ahmed is asking, is the intervention is standardized like single row versus double row? I don't think they comment on the technique, did they?
Yeah, no, there is another linked paper to the main paper mentions that every surgeon can use his own technique. There is no protocol for one technique for all the patients. So double row, single row, every surgeon can use his own preference in the management.
And this is another problem of non-inferiority. You don't need to keep certain technique, or you need to keep certain standardization of age, because basically you're just going pragmatic. So pragmatically, when you do open by your technique, when you do arthroscopic by your technique, I can tell you that pragmatically there will be comparable results and functional outcome. That's the problem of the pragmatic one.
Yeah.
And Ahmed Ghazi is asking, are both groups are age matched or stratified?
Yeah, they included only patient above 50-year-old, and statistically the age group is similar in both groups. Actually, they excluded most of the patient above 80, and the patient group mainly between 50 to 65 or something like this.
Yeah, and again, in the pragmatic trials, you cannot standardize the age. All what you do is you give a time like an age group or age window, and then you get all the patients in from this age window. It's so difficult again to standardize the age for both groups.
But there is no statistical difference between the age in the age group, in the age between the two groups.
Yeah, you mean on the outcome?
Yeah, I mean the outcome. The outcome.
Itself, you put an age range, so you take age from this to this. You cannot be because with a huge sample size, you can easily stratify the age in between both groups. You compare every age group for every age group. You compare the results, but with a small sample, you cannot. It's just an age range. Rami, are you ready?
Of course. Good evening, everyone. Thanks, Mo, for the nice presentation. My paper actually is much less easier and nicer than this. Actually, I cheated on Mohammed Shalan and chose the easy one. I'll start with share the screen. Share the screen. Can you see this?
Yeah, we can.
The paper is done in Cambridge in November 23, and it's a systematic review. And he wanted to assess the effectiveness of suprascapular nerve block in frozen shoulder. My name is Rami, and I work in Worcester Hospital. So the background of this is the frozen shoulder. We all know about this frozen shoulder. It's a common pathology in middle-aged female associated to diabetes and hypothyroidism. It goes into three stages: freezing stage and the frozen stage and thawing stage. And for all the three stages to happen, it takes about 2 years. And finally, the pathology starts to resolve and thaw by itself. The current treatment for the situation is the physiotherapy mainly we do, and intra-articular steroid injections, hydrodistension, and the surgical option, which is arthroscopic release of the capsule, plus the suprascapular nerve block, which is the topic of this paper. The aim of this study to evaluate the effectiveness of the nerve block in frozen shoulder compared to the other management options. And the outcomes was assessed against the patient outcome scores, like the pain and disability scores, and the pain scores, the VAS, and the range of motion at the shoulder, and the complications. The design is a systematic review and meta-analysis. They reviewed the papers on Medline, Embase, Cochrane Library. The inclusion criteria was any adult patient more than 18 years old with the condition in any stage. They didn't define any stage of the disease. The statistical analysis, random effect model, and Cochrane risk of bias, and the GREAT framework, which is a measure for uncertainty of the papers, of the results. They took 12 randomized control studies with total of 702 patients with a middle age of 55 years old. They compared it against the effectiveness of intra-articular injection, the physiotherapy, and the hydrodistension. And what they found was, against the intra-articular injection, and the patient pain and disability scores were much better with the nerve block, and it also improved the external rotation. When they compared it against the physiotherapy, it was more pain relief, and that's logic because they are injecting a local anesthesia. There was no significant change in range of motion or patient pain and disability index. The hydrodistension showed outperform in one study, which is I found surprisingly. The safety, there was no much complication happened due to the nerve block. The strength of this paper that they used the randomized control studies, which is a level 1 evidence. Comprehensive outcome assessment, they used pain and function and range of motion and measured it with mini score index. They used also the Cochrane of bias and the grade, which is, I'm not sure about this, but I think it's like measurement scales for the uncertainty. Practical relevance, it highlights the potential of the nerve block as a safe outpatient treatment. Critique limitation, number one, heterogeneity. High variability across the studies, like the follow-up duration was up to 12 months only. However, we said the disease can take up to 2 years to resolve by itself, so I think this is short. And the nerve block techniques, some of them made it with ultrasound guided, and the others made with landmark injection. The I2, which is the grade uncertainty index, showed I2, which is significant inconsistency. Clinical relevance, the pain score and the VAS score improvements were statistically significant, but not always clinically meaningful. Short-term focus, as we said, 6 to 12 months. However, we need more than 2 years. Exclusion of non-randomized control study data, and the combination of treatment. So they didn't inclusive result of nerve block combined with other treatment. They didn't use this. They used only the nerve block. Suggestion to improvement, address the heterogeneity. They need to make it on subgroups, like patients with diabetes, patient with in different stage of frozen shoulder. I think this could be difficult and like not very practical. We need long-term data, of course. Explore the combination of treatment, broader metrics, incorporate quality of life measures and patient satisfaction. Standardized methodology, use consistent one technique like ultrasound versus landmark technique. The conclusion of this, the nerve block is safe, effective option for managing the frozen shoulder, offers better pain management and range of motion compared to other methods. Clinical significance and long-term benefit remain unclear. I want to ask the audience, please, if anyone is using this technique in his practice. They didn't say in the study what are they injecting through the nerve block, and what's the duration of pain management, like 24 hours or more, and are they like dependent on pain control and physiotherapy, like help the physiotherapy and mobilization. That was not very clear in the study, and I think that needs more studies and clarification. Thank you.
Thanks, Rami, for the nice, quick presentation. Yeah, it's frozen shoulder, one is a painful condition for the surgeon to treat, like for the patient. And the interesting thing is always that the people don't know that it's self-limiting. So patient education, counseling at the start, once you have diagnosed the patient with frozen shoulder, is very, very important. It needs some patience with the patient, proper physiotherapy, proper pain management, and it will settle by its own. The nerve block is very helpful because the patient is in pain and you can never, and with pain splinting increasing the frozen shoulder problem. So you cannot convince the patient that this very painful condition, limited range of motion, will be okay by its own. So I think the nerve block is still helpful. I'm not practicing upper limb, but the time I was practicing upper limb, we do a lot of nerve block for frozen shoulders. Ahmed, I think Ahmed is an upper limb consultant in writing it, if I'm not wrong. So he doesn't use it in his practice. And he asking was there's a forest plot in this study.
Can't remember, sorry.
No, do you have a forest plot? How do you represent the results?
Can't remember at the moment. I need to revise it.
Yeah, so normally the forest plot will be presenting all the studies in the systematic review. Especially they analyze it, they did a meta-analysis, so it will be there. It shows you how heterogeneity is there, sample size for every study, and where is the study is clinically results of the study is clinically significant or not. So yeah, what's the mechanism? Ahmed is asking what the mechanism of action of the nerve block to control frozen shoulder. Also, is it used to treat primary or secondary frozen shoulder? Where did you disappear, Rami?
As I said, they didn't clarify what was injected. I think it's local anesthesia and long-acting local anesthesia, maybe adding.
Yeah, when I was doing this, we use Kenlog for Kenlog with local anesthetic, so 2% lidocaine with Kenlog. But I'm not sure what they do practice now in the upper limb. And I think it was mainly for primaries, so not for secondaries. With secondaries, we do hydrodilatation. Ahmed, if I can help us with that, he's practicing at the moment, so he has more detailed idea about this.
You can tell us some more if you can join Ahmed Rifai, please.
I have to invite him just a minute.
Thank you.
Ahmed, you're invited to the stage, so
please can you unmute yourself, Ahmed?
Thank you for inviting. So yes, I don't use suprascapular nerve block because of the logistics. It's time consuming and it's operator dependent. So usually it's done by the pain management team in our hospital, which the waiting is quite extensive. While intra-articular injection is really available, and I do it anatomically. I don't use any guidance. It's just intra-articular Kenlog. Yes, in our hospital, I think for suprascapular nerve block, they use Kenlog and local anesthetic. My personal preference is for, according to the stages, if it's the freezing stages, intra-articular injection physiotherapy, and if it's if the pain improved and it just still very stiff or stage 2, I will give them the option between carry on with the physio or just go on the list if they are fed up with with their physio. And personally, my preference is, after discussion with the patient, is either MUA or MUA plus arthroscopy. But I don't have any preference. I usually give it to the patient, but depend on the pathology. If they have single pathology with frozen shoulder, I'll just go for MUA. If they have double pathology, I'll go for arthroscopy.
Yeah, perfect. Any comments, guys, or questions? We have Ahmed with us, so yeah.
How do you inject steroids to the nerve? Sorry, did I hear right?
So usually in our hospital, it's done by the pain management team, as I said. But what I know is basically it's usually ultrasound guided injection. There is some studies done by anatomical, and we tried this for a while with the anesthetic team in recovery, especially post-operatively. Some use nerve stimulator, but and apparently the study showed that there is no difference. But anatomical, we find it is not that great. And usually, as I said now, usually our team in our hospital, the pain management, use ultrasound.
If I can, first time to me today to do suprascapular nerve block. Actually, I asked my upper limb consultant to do it. Just he used anatomical landmark, and the patient actually, the range of motion after the injection markedly improved, but actually the pain not improved the same like the range of motion, which is a little bit weird for me. But actually the patient have external rotation markedly improved, or the range of motion markedly improved, but the pain, as the patient mentioned, just a little bit improvement. I don't know. It's the first time to me to do the suprascapular nerve block, but actually anatomically it's just easy. Just you can just the posterior edge of the acromion and the medial edge of the scapula. I don't know what is the efficacy, because it might be with ultrasound guided much more effective than the anatomical guided injection.
I think this people use the anatomical landmark. I haven't seen like any surgeon using ultrasound. Ultrasound mainly for pain management people and anesthesia. Ahmed Ramadan is asking, what do you mean by double pathology to decide operative management of frozen shoulder?
I can take this. So basically, for frozen shoulder, if it's only so frozen shoulder. So we had a few patients. So post-traumatic rotator cuff tear with a frozen shoulder. What you're gonna do? This is a little bit of a problem. So usually, what happens is, some people say, okay, let's repair the rotator cuff, then deal with the frozen shoulder later. But usually, what happens is, if you try to manipulate the frozen shoulder and you're gonna do arthroscopic rotator cuff, everything is bleeding and it's quite difficult. Some people will do the manipulation and will opt to mini open rotator cuff repair, depending on the pathology. So this double pathology means that there is a pathology of the shoulder, or an injury or a trauma that resulted in a frozen shoulder, not a frozen shoulder in its own, not a primary frozen shoulder.
Yeah, that's clear.
Thank you very much.
Thanks, Ahmed. Any more questions, guys? Okay, perfect. So thanks to our speakers. Thank you, Rami, and thank you, Small. And thanks, Ahmed, for joining us for this very nice, fruitful discussion. Guys, we have the next Journal Club will be second Friday of March, and we hope all to be there. Thanks for your attendance, and the record will be ready on mid-all after straight away after the session. You will receive a feedback, and once you put the feedback, you will receive an attendance certificate as usual. Thanks for attending, and we'll be bringing this to an end. Have a good evening and a good weekend.
Thanks, Mr. Thanks, everyone.